My name is Dr. Hatem Eleishi. I'm a professor of rheumatology at Cairo University. The topic of my talk today is 5 reasons why rheumatologists should read their patients' MRIs. I mean, they should involve in reading patients' MRIs with the radiologist. When we go to our clinics, we rheumatologists, we see a lot of patients with osteoarthritis, facet joint syndrome, disc prolapse, fibromyalgia syndrome, soft tissue rheumatism. But those entities, reactive arthritis, AS, juvenile RA, lupus, jugular mixed connective tissue disease, PSA, rheumatoid arthritis, those autoimmune inflammatory arthropathies, those are the passion of the rheumatologist. This is why we go to our clinics with a lot of passion. We will diagnose, we will make a differential diagnosis, we will make a treatment plan. This is what we really love. This is the secret of our passion in our work. So, when I discuss today the topic of MRI and how important it is, I will use the inflammatory arthropathies, rheumatoid arthritis in particular, as a good example for the importance of MRI and how we should be involved in reading MRIs also. My main points today are: is MRI important in the management of rheumatoid arthritis? The kind of information that MRI provides in rheumatoid arthritis, and why we rheumatologists need to be involved in reading of the MRI. What are my 5 reasons? So, is MRI important in the management of RA? This is setting number 1. You're sitting in your clinic, you get a patient, a 35-year-old female. She has pain and swelling of the small joints of the hands for like 4 months now. She has morning stiffness for 2 hours. And you examine her, she has a tender joint count of, a straightforward tender joint count of 20, a swollen joint count of 15, her ESR is 60, her rheumatoid factor is positive, CCP is positive. So this is a common, classic, straightforward patient with RA. She sounds like RA when you take a history. She feels like RA when you examine her joints, and the labs look like RA when you check the ESR and the autoantibodies. Those patients are reliably and comfortably rheumatoid arthritis patients. In such patients, we do not need an MRI. To be more accurate, we cannot need an MRI. I will never tell the patient, you go and pay all that sum of money to get me an MRI to help me in diagnosing you. It's a straightforward diagnosis. I will not request an MRI. But if the patient for any reason gets me an MRI, it's good, as we will elaborate on that later on. It's good. I will use it, I will benefit from it, but I will never request it. So, in most patients with straightforward RA, in most situations, we can do without an MRI. We don't need an MRI. A less common, non-classic, non-straightforward patient with RA is a 35-year-old female. She comes to your clinic complaining of aches all over. She also has pain in the hands and feet, but her main problem is aches all over. She has impressive fatigue. She has a lot of pain. She has fatigue. When you examine her, the joints are tender, the PIPs are tender, the MCPs are tender, but also the shafts of the bones in the hands are tender, the soft tissues are tender, everything is tender. And when you check her labs, her autoantibodies are negative, her ESR is like 25. This is a very gray patient. Nothing is straightforward here. I call those patients fibromyalgic RA, gray RA. You cannot tell for sure that this is a straightforward patient. You cannot tell that this is an RA. Just a reminder, so if it's me and another rheumatologist seeing the patient, so one of us will say, yeah, it looks really like RA. The other will say, no, it's not RA. And you get into that debate. A reminder here, this is not the everyday situation with rheumatologists. The patients we see, most of them are straightforward anyway. But I'm speaking here about some, not all, of the early, not late RA patients. Sometimes they give you a hard time. And if it is 2 rheumatologists, one of them insisting it's RA, the other one insisting it's not RA, they get into that debate. In the end, you need to belong to the Egyptian culture to understand this slide. In the end, you say, okay, let's go to the Department of Radiology. There we will know if this patient has RA or doesn't have RA. What will MRI do? If you go to the Department of Radiology, what will you get from an MRI? The MRI is sensitive to the detection of synovitis and osteitis, bone marrow edema. The ACR and ULAR 2010 criteria, they base a lot of weight on the joint count. If I examine a patient and I get a joint count of 4, an MRI can increase this number to maybe 12 or 15 because it's very sensitive to the detection of synovitis. It is strongly suggested to add MRI to the diagnostic criteria of RA. It's not part of it now, right now, but it's strongly suggested to add it to the diagnostic criteria. MRI images as examples. Summary of MRI in a few seconds. Of course, not all of us rheumatologists are so interested into MRI and not so experienced in MRI. So I will just summarize MRI in only one slide. This is an oversimplification. I will compare the language of MRI to the language and the terms we use in plain radiography. In X-ray, the different images are called views. If I want to check the patellofemoral joint, I'll go for a lateral view. A sacroiliac joint, I'll go for a sacroiliac view. How about the MRI? Different images are called pulses. If I want to check synovitis, I should go for what we call T1 with contrast. I will not explain further beyond this level, but I'm just delivering only an introduction to MRI. If I want to check osteitis, I go for a T2 or STIR or T1 with contrast. If I want to check erosions, I go for the very basic for the anatomy, for a T1. Of course, each one of those, the T1, the T2, the T1 pulse, all of them will show you everything. But if you want to be so good at detecting synovitis, it's best to go for a T1 with contrast. If you want to be so good at detecting osteitis, you go for a T2 or STIR or T1 with contrast. So the different pulses will show the different abnormalities, but certain pulses are best for certain abnormalities. This is the point. With a background in anatomy, train your eye on how the normal and abnormal look like. In time, you will pick the abnormalities more easily. By the way, I'm not the MRI expert. I am very active in learning something new every day, and it really works. So, I want to go for synovitis. T1 with contrast is the best. This is a T2. On T2, any water, and any inflammatory water in particular, will appear whiter and brighter. So you see those white, this is water, this is edema, whether inflammatory edema or effusion. If you go for a T1 with contrast, which is the best, you see it's whiter and brighter now. The contrast is it makes it very clear. Osteitis, bone marrow edema, this is T1. It's not the best for bone marrow edema. On a T1 image, the water will appear darker, those darker areas here. But if you go for a STIR or T2 or T1 with contrast, like this is a T1 with contrast, you see the bright color, this is the edema. This is the white color, the bright color of the edema. This is another osteitis. See how bright it is on the STIR and the T2. So in that other patient, the fibromyalgic RA patient, the gray patient, yes, I would need an MRI. In such patients, truly an MRI could get us some black and white out of that gray colored setting. I would need an MRI. So in some situations, it is quite useful and informative, the MRI. Setting number 2. So the setting number 1, MRI is important in diagnosing some of my patients with rheumatoid arthritis. Setting number 2, it can help me to make a definite exclusion of RA or any true inflammatory synovitis. Let us say we get a patient, a 40-year-old patient. She has aches all over. She has pain in particular in the hands, and you're suspecting rheumatoid arthritis. And you examine her, and she is as gray as the query fibromyalgia patient. Like, she has tenderness of the joints, she has tenderness of the bone, of the flesh, everywhere. And you don't know if this is RA or this is some kind of fibromyalgia or something else that is not an inflammatory arthritis. If you go for an MRI and this MRI is free, then maybe you can end up telling the patient, I don't know what you have, but I'm sure of what you don't have. You don't have rheumatoid arthritis. Maybe she's peripheral neuropathy, maybe she's fibromyalgia, but she does not belong to the inflammatory arthritis entity. Settings 3, 4, 5. For differential diagnosis, you have a patient with rheumatoid arthritis, and after 4 years, the patient comes to you and she tells you, my dermatologist told me to tell you that I have skin psoriasis and it has been diagnosed only last month. And you revise the case that has been diagnosed as RA and maybe discover that it has been PSA all the time. That type of PSA that is so much like rheumatoid arthritis. If you have an MRI early in the disease and you pick an enthesitis, which is not part of rheumatoid arthritis, maybe you're diagnosing an enthesitis very early in the course of the disease. For prognosis, for early assessment of the erosive phenotype of RA, if you have rheumatoid arthritis, how can you tell that this patient will develop erosions after 1 year from now or after 2 years from now? Well, we have some predictors, but the gold predictor, what we can really rely on is detecting bone marrow edema on an MRI early in the course of the disease. This is the one finding that can really predict that this patient will develop erosive RA later on. And I can take an important decision to be more aggressive with the treatment regimen that I prescribe for them. If they don't have bone marrow edema, this is more or less a benign form of rheumatoid arthritis. For defining remission, clinical remission according to the ACR, it's you don't have tender joints, you don't have swollen joints, there's little or no pain, the ACR is normal. So this is how we define remission. Then when they study patients who have this clinical remission, they found that some of them they sneak to develop erosions over 1 or 2 years. When they studied them further, they discovered that those who have MRI evidence of bone marrow edema at the time when I diagnose a clinical remission are the ones who can still develop erosions later on. So if you really want to have an extremely accurate definition for a remission, it's better to have an MRI definition for remission and not only the clinical definition. So is MRI important in the management of rheumatoid arthritis? Yes, it is. It is important enough. It can diagnose patients with RA when the diagnosis is in doubt. It can help me to exclude rheumatoid arthritis in some patients who turn out to be fibromyalgia sometimes, who look so much like RA. It can help in differential diagnosis and exclude a spondyloarthritis, for example. It can help me in prognosticating and deciding which patient will need more aggressive treatment because he has bone marrow edema and will develop erosions later on, and it can help me define an accurate clinical remission of the disease. So MRI is really important in the management of RA. What is the kind of information that an MRI will provide? This is the list. I'm presenting this slide just for the sake of being comprehensive. Those are the ones that I concentrated on so far. But you still have, other than the joint disease, you have non-erosion bone injuries, and you have also soft tissue injuries in RA. So, why rheumatologists need to be involved in MRI reading? What are the 5 reasons that I should be involved also? In addition to the radiologist, of course, I'm not substituting it, in addition to the radiologist. The 5 reasons why rheumatologists should read their patients' MRIs. One would guess the first reason would be because it's important, as you just mentioned. The ESR is important. I'm not doing the ESR in my clinic. The anti-DNA test is important. I'm not doing it. The renal biopsy is important. I'm not reading renal biopsies. We only get the reports of those tests. So why should I be involved? This is the point, and I base on this slide the entire lecture. Where feasible, if it is possible, and at the same time indicated, there's a good reason to do it, the more the rheumatologist can extract clinical information relevant to the management of his patients by himself, the more his practice is under control. You feel more relaxed and confident about the decisions that you make. So, is it feasible? This is reason number 1, as I will elaborate now, and it's indicated. Yes, I will show you in reasons 2, 3, 4, 5 that it is indicated also. Feasibility. There are three situations in our practice that we face every day when it comes to the information that we extract to take decisions, clinical decisions. Situations where my data are under my complete control, situations where my data are under partial control only, and situations where things are out of control. What does that mean? Under my complete control, I take history myself. I do examination myself. I read the plain x-rays myself. And I depend very confidently on the data that I get from history, examination, and plain x-rays. Especially when I'm experienced in doing this. When I'm good at taking history, when I'm good at examining and reading the plain films. Partial control, I get lab results. While someone else did the lab, not me. They're sending me the report. Biopsy results. MRI reports. I get the report and I take action accordingly. We still use common sense and judgment to validate results. Sometimes we tell the patient, no, I want to repeat this CSR again. No, I want to go for a second opinion in this biopsy result or MRI. Okay. Can I move those partial controls to complete control? Can this lab result go to complete control? No, I cannot start a lab business and I cannot read renal biopsies. But MRI reports, why not? Why not go for MRI reports? It's anatomy, and we are about anatomy because we are rheumatologists, and we just train our eye on reading the MRIs. Situations where things are rather out of control. A patient with autoimmune iritis for whom you are prescribing systemic immunosuppressants. Now this is a very awkward situation for the rheumatologist because the ophthalmologist is the one who is seeing the patient, who is deciding that this is a very active iritis or this is an inactive iritis, and on that basis you will be the one to take the decision. You will prescribe the biologic or the immunosuppressant. So, like in this situation, this is the rheumatologist and this is the ophthalmologist. And the rheumatologist is telling the ophthalmologist, شوف لنا كده الايرايتس بتاعت العين اخبارها ايه بصلاح. He's asking him, check please, how is this iritis going on? Is it active or is not active? But the rheumatologist is very passive. He's just waiting for the decision of the ophthalmologist. So the ophthalmologist will tell him, ما خبيش عليك يا محمود الايرايتس شديدة قوي العين عينه مولعة. It's quite active. So you get this decision from the ophthalmologist and you take the decision, okay, إذا إنه البيولوجي. I will prescribe a biologic agent for him. So, back to our situations. Yes, it is feasible that we take the MRI reports from partial control and make it in the under control area. So, is it indicated? It's feasible. Is it indicated or not? Yes, it is indicated. Why? There are three different settings where the patient can have an inflammatory synovitis, but you still get a normal or inconclusive report. And there is one setting where the patient can have a normal MRI and you get a report that he has an arthritis. So what are those three settings where you have where you have an inflammatory synovitis but you get a normal report? Improper protocol, this is one reason. Disinterested radiologist and hesitant radiology reports. And the setting where the patient can have a normal MRI and you still get a report, we will elaborate on this later on. Misinterpretation of findings. It's not about getting a finding, it's about the correct interpretation of the finding. Okay, the only way to avoid those four situations is to be fully aware and knowledgeable of the MRI investigation that you are requesting. Knowledgeable of indications, picking findings, and interpreting the findings. So, let's start with this first one, improper or incomplete protocol. You request an MRI and you get an incomplete protocol done for the patient. I will describe an analogous situation always in the plain radiography setting because this is what most of us are quite familiar with. You request a plain X-ray of the knee and you get only an AP view, no lateral views. You cannot check the patellofemoral joint. You as a rheumatologist, by the way, if you do not have enough experience, you can contribute to this fault also. Look at this request. MRI request, kindly for MRI of the wrist and hands. Dr. MTL. You did not provide any clinical data. Typically, the radiologist should refuse this request because the radiologist should have clinical data. If you send this, you will not get a proper protocol done for the patient because they don't know what they are looking for. You need to add clinical data, basic requisite. This is a basic requisite. You better add the protocol also. So this is another request. Kindly for MRI of the wrists and hands, data 6-month history of pain and swelling of the small joints of the hands with morning stiffness of 90 minutes. We need to exclude an inflammatory synovitis. Protocol T1, T2, T1 with contrast and fat suppression stir. This is a typical protocol request that can get you the right protocol done. Reason number 3, disinterested radiologist. How do I learn? Where do I learn my MRI? Where do I get experience with this MRI? From my colleagues and my professors at the Department of Radiology at Cairo University. They are the ones who are teaching me. I have time to go to my professors every 2 to 3 weeks to get all my questions answered. But are the reports that I will be getting out there in the daily practice the same reports that I get from my professors? Of course not. It's not true. There's an interested rheumatologist and a disinterested rheumatologist. There's an interested radiologist and a disinterested radiologist. In every job, there's someone interested and someone who is not really quite interested. So sometimes you will face a disinterested radiologist. Not, of course, my tutors and my professors, someone else. I will face this situation. Like what? The radiologist did not bother to read the clinical data you wrote to know what you, and of course what you and him should be looking for. He comments on what ortho doctors are looking for. What I mean by ortho doctors here. Who is referring for MRI of the hand and wrist, for example, more? The rheumatologist or the orthopedic doctor? Of course it's the orthopedic doctor. So by default, the radiologist his eye is looking for what the orthopedic doctor is always looking for. You see this analogous situation plain radiography. You send the patient with queer rheumatoid arthritis and you describe that you had the clinical picture, pain, swelling, 6 months or 1 year. You're looking for erosions and all that kind of data that a rheumatologist is looking for. And then you get this, no fracture line seen. It's very frustrating, of course, for the rheumatologist because nobody bothered to read the request that you send to the radiologist. Inexperienced radiologist, he misses subtle changes that of great significance to you and reports the MRI as normal. Not all MRI reporters are radiologists specialized in MRI, of course. Hesitant radiology reports. What is the hesitant radiology reports? This is safe side reporting and any equivocal findings for correlation with clinical findings. It's like the analogous situation plain radiography. You send a patient with RA for a plain film and you write a full request and you get this report. Arthritic changes of the hands are seen. What is arthritic changes? What is the definition of arthritic changes of the hands are seen? You're sorting out PSA from RA, from erosive OA, and you get arthritic changes. It's a very vague conclusion, of course. Now we come to the last setting. The one setting where the patient can have a normal MRI and you still get a report commenting there is an arthritis. Misinterpretation of findings. Unless you are dealing with a rheumatological radiologist, we don't have that in our country, you will keep facing this situation. The talent and expertise here is not to pick the findings, but is to make the correct interpretation of the findings. Like reporting bone marrow edema. Reporting the presence of any marrow edema as an inflammatory synovitis. Bone marrow edema on the MRI of a patient with inflammatory arthritis is like a positive anti-DNA test in a patient with lupus. So specific, so committing to the diagnosis, on condition there is MRI evidence of synovitis. If I don't have synovitis, I can never consider the bone marrow edema a part of an arthritis. Bone marrow edema alone, consider a trauma, consider a tumor, consider anything else. But it cannot be my synovitis. It cannot be an inflammatory arthritis. It cannot be rheumatoid arthritis. So not every marrow edema is inflammatory arthritis. Recall a positive rheumatoid factor test does not necessarily mean rheumatoid arthritis also. Misinterpretation of erosions. The OMERAC defines an erosion on MRI as 4 criteria. A sharply marginated bone lesion with correct juxta-articular localization and typical signal intensity characteristics that is visible in 2 planes with a cortical break seen in at least 1 plane. So, if Bearing in mind those criteria, this is a T1 coronal plane. This is anatomy. And there's that erosion in the lunate bone. So, according to our criteria, this is a sharply marginated bone lesion. Yes, it is sharply marginated. Correct juxta-articular localization. In a long bone, it should be near the epiphysis, periarticular. It should never be in the diaphysis or the metaphysis. In the carpal bones, this is acceptable. And typical signal intensity characteristics, well, so far so good, but you need to have other views, T2 or T1 with contrast also, that is visible in two planes. When we go for the second plane here, because we have to sit in two planes, we discover that it is not an erosion. It's a foramen for a nutrient artery. So if you go by the rules, you hardly ever make mistakes. If you see this pulse sequence only, you probably diagnose this as an erosion. But if you go for another plane, you discover that it's not an erosion, or you confirm that it is an erosion. So this is visible in two planes with a cortical break seen in at least one, so you have to have another plane. In a recent study, small erosion-like lesions were identified in two planes in about 2% of metacarpal and wrist bones in healthy subjects. So this could be misinterpreted as an erosion in a patient with RA. But if you go by the criteria, you will find that unlike active rheumatoid lesions, these lesions did not enhance. You see this point, number 3, typical signal intensity characteristics. These lesions did not enhance after administration of contrast material and were not associated with bone marrow edema. So they do not fulfill the criteria. So they are small erosion-like lesions, but they are not true erosions. They are not part of an RA. So, to conclude, MRI is an important investigation for the rheumatologist. It's quite important. It is very feasible that the rheumatologists get involved reading their patients' MRIs, and it is very indicated also, as we just mentioned. Thank you so much. Thank you.